afternoon. So we're going to start this because it's going to be only about 30 minutes, kan? Right. Can you all see my slides? Yes? Dah nampak kan slide saya?
Prof, tak dengar suara Prof.
Tak dengar suara saya? Saya dah unmute dah. Tak dengar juga? Hang on.
Alright, sekarang dah dengar Prof.
Okay, sebentar Much better dengar dah?
Loud and clear Prof.
Okay, right. Can you see my slides now?
Yes Prof.
Okay. Right. I'm going to start now. The task is to talk about the CPC obstetric one. Bismillahirrahmanirrahim. I'm going to start. Right, this is the package one. Package one is Madam R, a 32 years old, para 1, referred for pre-pregnancy counselling. She has a Cesarean Section. She's performed at 36 weeks, gestation at 36 weeks for fetal congenital complete heart block. Baby is 2.2 kilogram and she has 2 late first trimester miscarriage after that. There are several investigations has been done, but she reported follow-up, so hence she doesn't know the results. And otherwise, she's quite well and she's not obese, and her blood pressure and her pulse rates are normal. So the question was asked is that identify the issue, concern, and discuss the assessment needed prior to counselling. That's 15 marks. Now, if you can see, these are the things that I highlight. She has Cesarean Section. It was done at 36 weeks for fetal congenital complete heart block. So that's one problem. Second problem, the baby was first trimester miscarriages. Right, so basically she has a Caesar, then followed by 2 miscarriages. Otherwise, in terms of her own health, she seems to be healthy without any problems. So if the issues that we should identify, that she has a baby with a congenital heart block, complete heart block, and the baby is also probably a growth restricted baby, and followed by that she has 2 late first trimester miscarriages, and she had a section. So these are the things that should be identified. So because then we can discuss about what assessment that we need. What we can identify is that she has congenital fetal congenital complete heart block. So on top of our mind, we should be thinking about anti-Ro, anti-La antibody. All right, maybe is there a major congenital cardiac anomalies such as ABSD, which actually cause heart blocks. Low birth weight, even for 36 weeks infant. So could be a growth restricted baby, can be SGA, all right. And there are 2 late first trimester miscarriages, could be APLS, because she also have IGR on top of it, and 1 Caesar at 36 weeks. It sounded like it is probably an elective Cesarean section, so her pelvis is not tested for labor. So these are the issues that we have identified in this patient. Feel free to ask me question in between. Tak ada, ya? So okay, tak ada. So we continue. Now, because they ask for an assessment, so assessment means we have to. Okay, that's right. So assessment means we have to look at. Because this is the question is what assessment would you like to do prior to counselling? Yeah? So because of this, we actually have to divide it into taking the history, because those are the ones that we know, so we have to know more into it. For example, if the patient has a baby that is born with congenital heart block, all right, the things that run in our mind, we must be thinking about anti-Ro, anti-La, and anti-Ro, anti-La usually is associated with connective tissue diseases such as SLE. So we must ask about symptoms of connective tissue diseases in her, such as joint pain, molar rash, photosensitivity, and all the things all the symptoms that could be associated with SLE, right? And since she has possibility of having APLS because she has two first trimester miscarriages, she has an IUGR baby. So you must ask about any thrombotic events that she may have, either within the pregnancy or outside the pregnancy. All right, and we must try to identify any other risk factors for this growth, supposedly or possible growth restricted baby, such as whether she has any preeclampsia, any suggestive of placental insufficiency, was it known before that. It's very important to know about the previous Caesar as well, all right, whether there's any abnormality found within the uterus that caused the baby to be small. All right, was there any significant injuries during that Caesar, which may advocate a repeat Caesar rather than a vaginal trial of labor? And it's very important to also identify about the miscarriages. What type of miscarriages is that? Is it miscarriages? Because miscarriage usually sounds a bit more ominous compared to, other miscarriages. And because some connective tissue diseases or even thromboembolic diseases is actually inherited in the family, so it's very good to know of any family history of significance in such manner. All right, any other question? Okay, we go on. Now, physical examination, when she came to us, she seems to be quite healthy, but it's good to document her whether she's pale, right? Because it's very important. Blood pressure, what's her weight, and to look for any signs of connective tissue diseases in her, such as whether she has any malar rash, any alopecia, all right, to examine her joints to see whether any joint deformity and things like that. All right, to see whether any evidence of DVT in her legs, all right, and especially to look for any secondary causes of hypertension, especially if the BP is high at that time. So these are the assessment in terms of physical examination. Otherwise, your physical examination may not be too, you may not find anything significant at that time. To me, the assessment is far more in terms of your history taking. The physical examination may not be much. Since she is actually having a normal weight, chances are, like things like PCOS or things like that may not be that high, but you can look for it if you wanted to, especially if, she has blood pressures issue when you come and book, because we don't know her blood pressure, right? Okay. Now, investigation, since she had investigation before, remember she has investigation before and she did not, she defaulted. So we are not able to see her result. So if the result is available, you should try to review the investigation. But if you cannot, so these are certain investigations that you want to do. For example, like we can do a full blood count. We have to see her hemoglobin status. To see a renal profile, because on top of our mind, what we're thinking about connective tissue diseases, you want to know her renal profile. You want to know whether there's anti-ro, anti-la antibody, because she's not pregnant at that time. So it's good to do the test during that time. Lupus anticoagulant, anticardiolipin, okay, ANO, ANF antibodies. Basically, these are the investigation to look for connective tissue diseases, especially SLE, like anti-diabetes standard DNA, Cpc4, and to do urine FME, just make sure that you can exclude proteinuria or glomerular cast. So these are the things that you can do at that point. Basically, we are looking for possibility of she may be having an SLE, possibility that she may be having an APLS, right? And you wanted to know whether there's any anti-ro or anti-la in her body, which can cause congenital heart block. And these are the baseline investigation to know that she's healthy to go on to the pregnancy, such as renal profile, her FBC, as well as to see whether there's any SLE or not. Oh, somebody write something on top of that. That's very nice. You can do that. Excellent. Okay, now package 2. Now, during her follow-up, we have no idea how many months later, but she reported that she has missed her menses for 2 weeks, and her self-urine pregnancy test was positive. So she's pregnant already, so that's what I'm saying, probably at 6 weeks POA. And she complained of muscle ache and joint pain. So this is what we're a bit concerned about, because she seems to be having symptoms of connective tissue diseases. She has mild nausea and vomiting. That's early pregnancy changes. Otherwise, the blood pressure is normal. Her pulse rate is a little bit on the higher side because she's vomiting. But these are the things that we can gather from the information in package 2. She came for pre-pregnancy counseling. We have done several investigations, and she went off and she came back already pregnant, probably about 6 weeks, and she has symptoms of connective tissue disease when she comes to see us the second time, and also symptoms of early pregnancy. So this is the investigation, right? They say interpret the results and Outlander Management of antenatal care. Okay, this is the package 2. So they don't give you all the result, but this is the result that if you were to look in one shot, you know, this is mainly looking at the connective tissue disease screening. So they have the C3 and C4, the interpretation of C3 and C4 are within normal limits. We have the lupus anticoagulant, which is high. Okay, we have anti-cadolipin is also high. The CRP also very high. So this suggested that she may have anti-phospholipid antibody. Right, she has ANF or ANA. So this is positive. All right, this is positive. So chances are with this positive and anti-DNA also high. Okay, not high in the first limit, but quite high already, and definitely over the normal limit after the second time been done. All right, and this is quite recent, and chances are she is actually currently having SLE. Now we know that she probably have an SLE with possible antiphospholipid syndrome. So the thing is that, is she having an active disease or not? And look at the C3, C4 is within normal limits. So chances are she has SLE, non-inactive disease, but she is also APLS. All right. Now these are the two things that is quite important, because SSA means she has anti-Ro positive here. All right. This is quite important. SSB not positive, that's fine. But SSA is positive. These actually suggests that the chances of the patient with this one is positive together with lupus anticoagulant, the baby may have, the mother may have anti-Ro, antilla, and therefore the risk of having a repeated recurrence fetal congenital heart block is on the higher side. Yeah. So as a conclusion, this patient with this investigation, she actually have SLE, not active disease at this point, but she also have APLS, and chances are there's also anti-Ro and antilla. So that means she may actually have a repeat case of having another congenital heart block. So this is the, so having this in our mind, we should then try to manage the antenatal care, because it's only 6 weeks. All right, it's supposed to be about 6 weeks. Okay, so this actually is the answer that's been given. Okay, there are some answers that have been given awarded 1 mark each. This because it's important, right? And there's also additional marks to make it. You know, if you were to mention this, chances are you have more marks to that. So important marks here for the interpretation is to be able to make a diagnosis that is probably an SLE because of the anti-DNA and anti-phospholipid or anti-nucleic factors positive, high anti-cadolipin and lupus anticoagulant level indicating APLS, and the disease is not really active because the normal C3, C4 level. All right. Additional thing is this one, SSA is positive with the presence of this, meaning that the risk of having congenital heart block is very high. All right. This is basically trying to make a diagnosis of ANA, because ANA is not specific. ANA and anti-phospholipid, double strand DNA will make it most likely an SLE. All right, and these are the things that the NA, where they look at the just now the SSA and SM. Nowadays they say this SM antibody is not really a great marker for SLE, but doesn't mean that having this negative is not SLE. So at this point, what we need to be aware of with this interpretation is that we know the patient actually have SLE and also APLS, most probably with anti-Ro, but at the moment in time, alhamdulillah, the disease is not active. So how are we going to manage this patient, having this in our mind at 6 weeks POA? It's quite early, yeah? Okay. So this is the final interpretation. All right. So we actually, in order to manage somebody, we must be able to identify the risk. What are the risks that may arise with this diagnosis? So of course, with the mother first, having an APLS, the risk of VTE is very high, whether it's arterial or venous. Having risk of preeclampsia is also quite high, about 30 to 50% because she has SLE, APLS. She may have heart syndrome, and usually it's quite early in second trimester or even early third trimester. And obviously, a Basho placenta is also increased risk in her because of the APLS. Okay. In terms of the fetus, the risk of IGR is there. Of course, fetal loss because of APLS, and also recurrent sudden complete heart block. So these are the risks that we identify. Having identified the risk, then we plan our management from the risk, meaning that how are we going to anticipate and whether can we manage it or prevent it. Yeah, this is the question that we must try to answer during our antenatal care plan. Okay, so the aim is to monitor the SLE activity. We cannot stop this. This is a disease that we cannot stop. We can probably control it, so we monitor the disease activity. We have to try to ensure the fetal survival. Remember, after she had her first child, she has 2 losses. So we want to ensure that this time the baby would survive. And you know that with APLS, the risk of having VT is on the higher side, as well as she's also having SLE, right? So she has a lot of geometry process going on. So the risk of having VT is very high. So we are going, this is the aim for care. All right, this is our aim. First, we have to confirm the viability. If we manage to date the pregnancy, we should do so. We can start the aspirin at this visit or even later, but low molecular heparin we can start once we see the fetal heart activity. We have to co-manage this patient with physician, okay, especially when with the SLE disease and things like that in the combined clinic. And throughout the whole pregnancy, we should monitor for active SLE. And also, we should anticipate preeclampsia because in this case, her risk of having preeclampsia is on the higher side. We should arrange for an NT. Remember, she's only 6 weeks. She's high risk of having a fetal anomaly, congenital heart block, things like that. And then we arrange for a detailed scan later between 18 to 22 weeks. Since we are concerned about her preeclampsia, we should monitor the blood pressure, monitor renal profile, proteinuria, and every visit or monthly. It's good to have a baseline urine PCI as comparison, because we know that chances that she has preeclampsia, you can get higher, or PCI to PCR, doesn't really matter. Since we know that the risk of IGR is also high, we have to monitor the fetal growth and well-being, not just the growth, but also the well-being, usually after 26 weeks, 24, 26 weeks, because that's where the baby will start to have their own growth spurt and to see whether they're actually following their growth spurt or not. And fetal echo is very important in cases where we suspected could be having a congenital cardiac anomalies, either in terms of the structures or the rhythm. So, and then if we manage to bring this pregnancy with all our monitoring, all right, we can actually plan for delivery at 37, 38 weeks. At that time, the method of delivery will be discussed with her, whether she wants to go for a trial of labor, okay, or she wants to have a cesarean section because of a bad obstetric history, isn't it? She has lost 2 pregnancies already. So, but the timing is about 37, 38 weeks. Now, I do not think so there is going to be any benefit of trying to extend the pregnancy beyond that. Any question about the plan of management? No?
Okay. Prof, can I ask, Prof?
Yeah.
There's a point monitor fetal growth and well-being after 26 weeks. Is there any particular reason after 26 weeks, Prof?
Hello, tadi dah cakap dah growth spurt sayang.
Oh, tak apa dengar, Prof. Okay, thank you,
Ya
Prof.
ke? Yeah, suddenly baby sampai about 24 weeks, they tend to sort of like have about the similar growth spurt, but after that they will have their individual growth spurts. So that's why you do not see IUGR anything lesser than 24, 26 weeks, but you will find a significant IUGR after that. If any IUGR happened prior to that, is an early growth retardation or restriction, then usually the prognosis of those babies are very, very poor. Okay.
Prof, another question. Kalau saya masukkan in terms of PE screening macam uterine artery Doppler semua tu ada markah tak, Prof?
Ada, sebab yang ni orang bagi saya template kan. You have, because chances are, because it is very important to monitoring kan. You can answer that in terms of doing your screening, but the thing is that it's mainly for your determining the rate and the aggressiveness of monitoring kan. Kalau you punya PE screening is low risk, then chances are you're not, you probably be a bit more reassured. So you probably just monitor her macam biasa kan. Tapi kalau you punya risk is higher, then chances are your monitoring is going to be very, very close. Since we already started on aspirin, maybe if the aspirin is only about 100 grams, you can increase to 150 milligrams, take it at night and things like that. Okay, all right. Ada soalan lagi?
Prof, another one question. In this type of answering CPC, do we need to create a situation in case macam in this one management of antenatal care, if let's say patient suddenly during antenatal follow up having symptom of flare, semua tu kita kena wujudkan that situation ke ataupun tak perlu, Prof?
Selalunya tak perlu ya, sebab you just tell sort of like just a grand management lah, or a sort of like a general management what you want to do. That's the reason you actually have your aim there, all right, because you want to monitor for symptoms of SLE, the activation of become active SLE and things like that, rather than you actually because takut nanti you spin off from there, then you actually did not cover the rest. So this is good to cover the rest, alright, and you can see the marks is about 15 marks. So and then before that kita kena identify problems kan, there's already 5 marks kat situ. So 10 marks punya question roughly will be about 10 answers, 10 to sort of like easily 10 to 15 lah, ataupun 10 to 13 macam tu. So nanti takut you spin off, you tak balik kan. Macam you nak masukkan the PE punya screening, that's one of it. Yeah, because dulu mungkin this question was made, it was that thing wasn't a big thing. Now it's the thing kan, so you can put it in there. All right. Okay. All right.
Thank you, Prof.
Okay. All right. So go to the next one. Okay. Package 3 kan, package 3 she was counseled. Okay, that's the counselling that we actually give her kan, about care and things like that, and she agreed to take low dose oral aspirin, but she declined low molecular weight heparin. All right, so this one actually should ring the bell to us, right? Because chances are you're not able to control the APLS very well. You may be able to control the SLE a little bit, but you'll not be able to control the APLS. Probably even the preeclampsia pun maybe not easy to be controlled as well. Okay, so she attended antenatal clinic regularly. She has serial ultrasound scans, and they said the baby is growing well along the 5th centile, Doppler all normal. So she has an SGA, which you're not actually surprised kan, with all the medical condition that she had, but it's growing along satisfactory. So you know that this is just probably an SGA within your care. And then at 32 weeks, she developed dizziness and headache. She has no blurring of vision or epigastric pain. Then you find out the blood pressure is high and the pulse rate is normal, but on the higher side of blood pressure. Remember, her booking blood pressure was normal, pre-pregnancy blood pressure is normal, and her urine albumin was 2+. So discuss the management. So when you want to discuss the management, kita mesti selalu kena highlight apakah masalah yang terkini, and then what current condition you know. So we know that she's only on low dose aspirin. She currently presented with a symptomatic preeclampsia or probably a severe preeclampsia, okay, but symptomatic preeclampsia for sure. And then you know that she is currently only on aspirin, but not on low molecular weight heparin. And at the same time, you know that at the moment the baby is sort of like on the 5th centile, but otherwise this is having an SGA on board. Okay, so these are the problems. The biggest problem is she has symptomatic preeclampsia. Okay, so let's deal with that. Discuss your management plan. Right, we know that she probably has severe preeclampsia because she came with symptoms. She came with a raised blood pressure and she has a urine protein 2+. So when she has this kind of condition, definitely the answer, hopefully everybody would jump in to say it should be an inpatient care rather than outpatient care. And not just enough to say it's inpatient care, you must be able to tell us where you want to bring this patient in. So you can say that inpatient care, preferably in HDU for close with the BP symptoms, monitoring worsening of the PE symptoms, because she came with that short history and symptoms. So you actually have to do further assessment. Okay, so this further assessment, basically this is what we tend to do lah kan. We look for symptoms of complication of PE, such as intracranial hemorrhages kan. Dia cakap tak ada headache, tak ada blurring of vision, subcapsular hemorrhage, primary edema. You have to monitor, you have to look at her BP and vital sign. You can do, you still want to do your reflexes, tak salah I, I think in ACOG dah tak kisah dah reflex, dia tak nak tengok reflex dah, but it's okay, you can put that you want to look for reflexes, when we read that urine protein is 2+. Okay, we want to look for evidence of edema in the legs, or edema in non-dependent area, also benda kan. And you have to have investigation, FBC. This is very basic. Since it's severe preeclampsia, you can do population profile. You can do your urine protein assessment. Remember, we have a baseline PCR, so we can do a PCR. Yes, and CTG. Dah habis dah masa saya ke? Oh, dah habis masa? Belum lagi. And every menstrual sulfate for prevention of IV menstrual sulfate for prevention of preeclampsia, as well as for fetal neurological protection. And we can start an antihypertensive, either oral or parenteral. This is very political answer, ya. Tak nak just tulis start antihypertensive, oral or parenteral, doesn't really matter. You want to start antihypertensive, ya. Don't argue, jangan tulis banyak-banyak lah, just right there, because it's very important. You don't know because you have only one blood pressure. Kan? And that blood pressure doesn't seem to be good enough for an oral parenteral, but she has symptoms, so put there either oral or parenteral, that's fine, got marks there. You can give antenatal corticosteroid for fetal lung maturity. Since we need the baby to be delivered early because she has severe preeclampsia, we have to inform the neonatologist for ICU backup first. Maybe mother the SLE kan, and next definitely for Caesar. Okay, counsel for Caesar because this patient cannot wait lah kan, because she already got severe preeclampsia, symptomatic. And if you do the Caesar, I think in terms of the Caesar, I think regional anesthesia because it's much better to control blood pressure. That's good. There's another point we can bring up. You can then postnatal care in HDU untuk amniosum sulfate, DVT prophylaxis. Remember, she has APS, so this one must be longer than just your 10 days post-op. It must be 6 weeks. IUCD as your contraception. You have to probably avoid hormonal lah, because she has APLS and things like that. And again, she should have a pre-pregnancy counselling before the next pregnancy. So this is sort of like the management for everything until postnatal. I run through the answer. Kalau ada masa, you tanya soalan. Okay. Right. Package 4, last package. The emergency Caesar was performed when they have finished the dexamethasone and there is retroplacental flow of 300 mils. So it looks as if this patient actually suffers from or having a rupture placenta. And then when they clasp the uterus, there's bleeding. All right, there's bleeding. And the NS tell you that it's very difficult to maintain blood pressure, assuming blood pressure is coming down. So you have to convert to GA because of this. So what's your most likely diagnosis and etiology? 5 marks, and then outline your management at this stage. Okay, so diagnosis is she actually have a primary postpartum hemorrhage. Causes can be the IVC because she has a bloodshot placenta, can be uterine atony because of covalent uterus, or because she has been given magnesium sulfate, can be trauma, which is a bit lower on the list because we have no idea. We have previous scar, kan? Maybe there's some addition ke bleeding ke. Retain POC in Caesar usually tak berlaku lah kan, tapi kalau it may be, because we have no idea where the placenta is, kan? But that is the reason why it's not listed very high on the list, because it's Caesar, kan? So this is the diagnosis and this is the possible etiology. So 1 untuk diagnosis and 4 markah untuk etiology. So that makes it 5. So the last one is Outlander Management. So basically, these kind of cases, you must activate red alert and massive transfusion protocol. Right? You must try to identify the cause, because when we identify the cause, we must manage. Any case of PPH, uterine massage come first, because we're looking for the cause, looking for the other treatment to be instituted, massage the uterus first, and we must check the placenta for completeness. That takes away one huge headache. Done, complete is the placenta is complete. Now we can return back to the uterus and deal with the uterus as such. Right, we must examine the uterus and surrounding organ for any trauma. No trauma, just a Cesarean section, done. Second problems, tolak tepi. Now tinggal the IVC done, juga problem with atony, kan? So atony is maybe if patient on magnesium sulfate, stop it first because they can actually cause uterine relaxation. Remember blood transfusion because patient has lost quite significant amount of blood, and the IVC regime if there's evidence of the IVC, and then institute the medical therapy. So you can use carbetocin, high dose of oxytocin infusion. You can use acid. All right. Of course, since she has preeclampsia, you must avoid insumetry. Prostaglandin 2 alpha, which is hemabate, to be a bit careful because this can actually cause vasodilatation and cause hypotension. It might actually cause in the answer scheme they mentioned as to avoid it. Although some of us sometimes tak avoid phone. We have our NS. We hope we can actually the blood pressure can be maintained. Right. Now, if your medical treatment is not successful to arrest the bleeding, you might opt for a surgical option. These are the surgical options. I'm sure you all know this very well. Kan? Soalan jawapan di senang je. Right, and you must always remember, you must update the family member, especially when the condition is getting worse and possibility of hysterectomy. And let's say you end up with hysterectomy, post-operative care is either in ICU or HDU. This kind of patient cannot be back to anything lesser than these two places for intensive monitoring, because remember they have bleeding issues, okay, they might be, and they have massive transfusion, so you must look for any of this complication. And remember, since she also have APLS, she can always develop VTE, VTE, and then prophylaxis can be started when we see no more active bleeding. But while waiting for this condition, we can actually give start on taxstockine, cuff compression pumps, and hydration can be instituted in order to prevent from thromboembolism. I think that's the answer. That's all the answer. Any question you want to ask? Oh, finish time already. No question can be asked.
There is 2 questions in chat box, Prof. If the question asked regarding outline, can we write in point form like what you show instead of paragraph?
Okay, good question. Selalunya point form ni tak digalakkan lah. Itu sebab dia answer scheme. Kan? That's why it's in that paragraph form. In that point form. In the actual way of answering this, it is much better to write it in like essay. Boleh?
Boleh, Prof. So another question, is defaulting follow-up is an issue to be concerned, so that the compliance to follow up upon next pregnancy.
Well,
so
you can actually, because the issue to be identified kan atas tu kan. Yeah, I mean you can put it in, tapi it's good that you are very attentive to that. But in the marking scheme, the examiner may opted not to give marks for that now. But it's good. I would rather you are doing a bit more than you doing a bit less. Okay, because sometimes the mark is only for 5 marks, so they actually have to 4 or 5 marks. They actually have to highlight maybe the first 5 that is far more important because it's the priority of problems. So yes, I am not saying that please, if you find that is also an issue because she's not compliant, yes, definitely you can list it down. Whether that is included into the marks is something that you may not know, and the examiner will only know when they buka the answer sheet lah. Faham So write down, if you think there's a problem, write down. Who knows, maybe there's mark for it. Okay. And then the question.
Any more question? Any more question? You can ask directly. You can unmute your mic if you want to ask a question in between the package. If there is no more question, I would like to thank Associate Prof. Shaila for very interesting discussion. We shall continue our obstetric CPC discussion too by Associate Prof. Dr. Sofia Sulaiman. She is a consultant lecturer from University Malaya. The floor is yours, Prof. Sofia.
Prof. Sophia, can you unmute the mic first, Prof? Prof. Sophia, can you unmute your mic first? Can't hear you.
Can you hear me?
Yes, thank you.
Okay, so now I just open up my slides, right?
Yes, you open up your slide, then press the share screen green button.
Sekejap ya, let me just press on share screen. Right. Okay, Can you
Yes,
see my slides now?
yes, you can put in the full view.
All right. Okay.
Okay, thank you.
All right. Sorry for the little bit of delay. Okay. And thank you for inviting me. And this is very important, I think, for you all to practice for the exam to come. Okay. I have about half an hour to discuss 4 questions on CPC obstetrics. And I was given the task to discuss this interesting CPC. So I'm just going to read about this question 1, package 1, which is 18-year-old who is a housewife, primary gravida, booked at 7 weeks with asymptomatic and routine analysis suggestive of urinary tract infection. She was treated with antibiotics, vancomycin, and then repeated urine analysis 11 weeks, 7 to 11 weeks, about 4 weeks later was normal. Had 6 antenatal visits and uneventful except for persistent proteinuria. All right. So when you read this particular paragraph, I think as who's sitting for the exam, or anybody who's read this, we have to think like, if I am a doctor who's seeing this patient, okay, I have this patient 7 weeks pregnant, asymptomatic, I start commenting already on what I see, and what would I do differently. All right, because the question number 1 is related to that. And then after 6 visits, she at 30 weeks, she presented with lethargic, vomiting, loin pain and fever, low blood pressure, tachycardic, and also very tachypneic, about 24 breaths per minute. And investigations results shows as a total Y of 21,000 and creatinine of about 131. Okay, in this pregnancy, we expect it to be a bit low, the creatinine, and the leukocytes are about 3+. Okay, so question 1, critically appraise her antenatal care. So when we see this question, okay, I was saying just now that, we have to imagine ourselves there. Would we do differently or not? Or would you like to know more? Okay, so you have to critically appraise. You say, do you think enough history or not in this presentation, that particular paragraph? Not enough, isn't it? So that even though she's young and 18-year-old, whether she has an underlying medical condition or not, whether she has diabetes or not, whether you just had a discussion about SLE, APLS, so we need to know more about that. So the history is actually not complete. Okay, you can start by commenting that, or say that, from the history given, I would like to know more regarding so and so, regarding her medical condition, and also whether she has, according here, any nephrotic or nephritic syndrome before in her earlier, even though she's young, a possibility is there. Then you look here, okay, it says here routine urine analysis, all right? So it just reveals features which is suggestive of urinary tract infection. This one we normally do, isn't it? We see proteinuria, we send for microscopy, urine analysis, you look there, probably white cells is raised, nitrite is positive, and very suggestive, you can start her antibiotics. What's missing here? There's no mention about a urine culture being sent. Okay, you should send a urine culture together, because when you do a screening for urinary, for urine, okay, and any possibility of asymptomatic bacteriuria which carries, morbidity in subsequent pregnancy. And how would you manage an asymptomatic bacteriuria yourself? Okay, what we normally do is, if let's say we send urine culture, okay, you have to think vancomycin is something that, I used when I was a medical officer in district hospitals, and I have not much of choice, and that kind of thing. But now we know that, okay, in pregnancy, okay, even though this is just ampicillin, okay, there are a lot of resistance to this. So you may not be treating this particular patient. And look at this, it's only given for 5 days. All right, so you know that, from I'm sure you have read through all these asymptomatic bacteria, they compare between a single dose treatment and a few days treatment. They found that persistent bacteria, with a short treatment of antibiotics compared to a longer treatment of antibiotics. And you should be repeating the urine analysis and culture, okay, 1 week after she completed the antibiotics, meaning that if you give her a 1 week of antibiotics, ask her to come back again, review the culture, all right, and probably 2 weeks down the line, should be repeating the culture again and see whether you've cleared the bacteria or not. But you have to remember asymptomatic bacteria, meaning that it's a significant infection, significant 10 to the power of 5 to say that this is actually asymptomatic bacteria. So you can comment on that as well on the treatment of the antibiotics, all right? And then on top of, there's also no mention about other advice. Okay, you know that in the first trimester, women, they have nausea, maybe vomiting. You don't know because it was not written there. All right, and it should be elaborated. I think you should ask whether she can tolerate orally well or not. Okay, advise her on taking more fluids to make sure, teach her a little bit about how to flush this infection. Okay, hygiene, how to keep it clean and so on, because the physiological changes starts happening in the first trimester with all the hormonal effect, the smooth muscle relaxing and so on. So you tend to get more, a possibility of ascending infection, and in females the urethra is also quite short, so you're more towards risk of having urinary tract infection. So this advice should be given, meaning that you should empty your bladder regularly, don't tahan kencing, drink plenty of plain water. And if she doesn't have diabetes, if she has diabetes, advise her regarding, sugar controls and so on. So these are the non-pharmacological measures, all right? Then follow up, we mentioned this, I think, because you should know how to treat or how to monitor for asymptomatic bacteriuria. And of course, other investigations regarding, when she has a urinary tract infection, you send for all the standard renal function tests. Okay, and think about why does she have this if she doesn't have a history of nephritis, not diabetic, why is she having a significant infection? You can send for an ultrasound to look at the kidneys. Okay, then the second question is give your provisional diagnosis. Okay, this one here, provisional diagnosis. So this is regarding the 30 weeks when she presented with fever, loin pain, low BP. So she's actually already in septic shock actually, okay, because hypertension, tachycardia, tachypnea, fever and pain. So that's actually urosepsis, all right? And when they present like this at 30 weeks gestation, that's considered emergency acute. Okay, you have to treat urgently. Okay, you have to have a multidisciplinary team involvement because she's one premature, involve significant sepsis, so anesthetist needs to come in. Okay, and probably the renal team regarding treating her urine culture and so on. You need to find out about that. So ICU management, definitely remember she's pregnant, her immune system is low, okay, and her risk to the fetus is also very high, especially when you know that the likelihood of ascending infection in this case is very high. Probably that's the cause of the septicemic shock. Okay, and she's already in shock. Okay, so what do you do when patient is in shock? All right, so of course we're talking about resuscitation. Okay, you start with fluid resuscitation. In her case, you need to hydrate her. Hydrate for septic shock is very important. Okay, then may need or may not need, you see, like vasopressor to improve, these are all ICU care basically, right? And central line to look at hydration level and monitor the blood pressure closely. Steroid, we have to think about this as well because steroid, there are two, aim in giving steroids. One is you're thinking about delivering the fetus. Okay, that's one. Second is it may be a treatment for this shock. All right. So there are two things that you have to consider steroids. You're thinking about mom and thinking about the baby. And management, you need the antibiotics for this. And of course, it's a broad spectrum, and you have to think urinary tract infection in pregnancy. What are the commonest organisms that cause usually got sepsis? Think about E. coli. Okay, that's the first one. Of course, there are others like Proteus, Klebsiella, and so on, but the commonest one is E. coli. And think about the antibiotics, which is broad spectrum that covers cases of septicemic shock and likely from ascending infection or pyelonephritis. All right. And of course, oxygen, okay, she may need to be, you don't know, you have, meaning that you have to assess at that time, and with the multidisciplinary, you know that she needs to be managed in ICU, whether she needs ventilation for a while or not, because there's always risk of DIVC, there is risk of pulmonary edema from the complication of shock. Renal function need to be monitored. Okay, because you don't know whether, you're talking about ascending infection, it could be some, small pus or micro pustules that affect the kidneys and may cause a rapid deterioration of the renal function. Okay, and of course, investigating why does she have this, she has underlying diabetes, underlying connective tissue disease, or, whether the ultrasound is, to suggest any stones and something like that. Heartbeat baby, okay, whether the fetal heart is alive, whether the fetus is still alive or not. Okay, if you can do CTG, but at 30 weeks, a woman in shock, sometimes not that easy, but you can just put there, I said, okay, CTG is good to look at a short term, whether, the heartbeat and what's the pattern like, whether they're distressed or not, because the mom is already definitely in shock. So you anticipate all that problem. And ultrasound scan, a bit difficult, to assess for IUGR on one ultrasound, because there's no mention about an ultrasound done earlier. So you can correlate, okay, but this is one way of monitoring. You can look, estimate the size, I would say, okay, because if you're thinking about delivery, you want to tell your pediatric colleagues regarding these fetus. Okay, then true enough, okay, what we're saying, she was admitted to ICU. Okay, she needs to be intubated because she was tachypneic, hypotension. Okay, and she is on inotropic support. Okay, and on the third day, okay, unfortunate for her, the fetal demise. Okay, which is not a surprise because she's in a severe, she's in sepsis and presented with her shock, septic shock. Estimated fetal weight 800 grams. So you have to think 30 weeks, 800 grams. Is that correlating or not? Okay, a little bit small, isn't it? Okay, the urine and blood culture grew E. coli. Okay, that's what we said just now. We're thinking about what are the commonest organisms that can cause urinary tract infection, pyelonephritis. And you have, the sensitivity to ceftriaxone. Okay, so NMDT meeting, okay. So imagine that, you have a fetal IUD, a mom is not so stable now, still intubated, but we know the antibiotics that can treat this septic shock, this sepsis. Okay, hopefully she's no more in shock. We corrected that, hopefully. Okay, so okay, to help the mom to maintain ventilation, and also to improve, hopefully to improve the renal function, because you never know the toxins from the fetal IUD, and mom have to clear it, and also she is not able to clear her own probably yet. Okay, so now the question is management of this fetal IUD. Okay, what are we going to do? It's a lot of marks here. It's about 10 marks here. All right, so you have to imagine yourself there. You have a patient who's not so well, and now you got an IUD. What are we going to do? She's a primary gravida and she's only 18 years old. All right, so first, you have to confirm first, I would say. All right, confirm the absent heartbeat. All right, because it was just mentioned the fetal heartbeat was absent. All right, I mean, like with daptone and CTG, you can't pick it up. I think it's better you said that it will confirm it, okay, with an ultrasound to look or to see whether there's presence and absence of fetal IUD. That's important. All right, first. Then after confirming, how are you going to break the news? Okay, it's not easy to break the news now because she's intubated. So the next person who's in charge is probably the family. Okay, so with the multidisciplinary team, maybe we can invite the family and discuss, break the bad news, telling about her condition. Now you got fetal demise, and discuss on the options. Then when it comes to the option, then what you're going to do. All right. So during the ultrasound scan, in addition to looking at the fetal heart, whether it's still absent, the absence of the fetal heart, we are looking, because we are aiming, in these kind of cases, really we aim for a vaginal delivery. Okay, but we had to look any contraindication or not for us to do the vaginal delivery. Is it transverse life, for example, because she's only 30 weeks. Okay, where is the placenta? Are we dealing with a placenta previa or not? No point saying you want to try vaginal delivery, you put a scan there, you see it's placenta previa. Okay, and of course, clinical assessment regarding the size, even though you have a machine or ultrasound will tell you the estimated fetal weight. Okay, and don't forget to do a vaginal examination. What do you expect from vaginal examination? She's only 30 weeks, primary gravida, probably it's not favorable, right? Okay, so these can be discussed, all right? Then her bloods, okay, we know she's in sepsis, even though she's already about 3 days. Okay, just now we're saying that the possible complication as she might be in DIVC. So whether it's corrected or not, okay, and we know that urosepsis is also related or associated with anemia. So whether that is corrected or not, all right? Because you're thinking about induction or delivering, you do not want to induce, or if you need to do cesarean section, for example, a patient with an abnormal DIVC is in DIVC. So get bloods ready, okay, in case she bleeds. All right. Then discuss if there's no contraindication, okay, for vaginal delivery, then we should aim for vaginal delivery. So just imagine that you're discussing this with the patient's family. So what's the important thing, the pros and cons? A small fetus, the success rate is better compared to, induction of labor or termination of pregnancy with a live fetus, okay, because it's a dead fetus. Okay, so usually the successful is better. And another one is, you have to make sure that all the are corrected, okay, before you decide for induction of labor. And then while doing after Bishop scoring, you can kind of give an idea, okay, what are we going to do? Then you can also discuss, can we do induction of labor with a balloon or not in this case? Okay, what normally we do is medical. Okay, and then there's a discussion between whether you want to use prostaglandin E2, which is prostin, or you want to use prostaglandin E1, which is Valium. Okay, and what about balloon? A lot of people now, use balloon or mechanical methods. So in this case, we said we can discuss it, even though, she's a primary gravida, 30 weeks, and then we're worried about sepsis. Probably not a good idea to put a balloon for an induction of labor. So probably, and then you can discuss whether prostaglandin E2 or E1, okay, depending on the size of the pregnant uterus. But to ripen the cervix first, if the size of the uterus in 800 grams, okay, if 30 weeks we expect to be bigger, 800 grams, probably the size of 28 week size around there. So that's kind of like a border. Okay, you can prime first, you said with Valium, okay, and then followed by prostin, you can prime with prostin first to ripen the cervix, and then what's the maximum number of prostin that can be used, may need repeated cycles, that kind of thing. Or you can say ripen, we see after 2 is not successful, we can rest. So these need to be discussed, the pros and cons, all right? And another thing is, okay, now she's still intubated. When are we going to induce her? Can we wait, okay, or should we do it immediately? Okay, so these are also like a datching lah. I think she's in sepsis. If we leave the dead fetus inside there, anything that can lead to worsening condition, and then not helping her with her ventilation and so on. So they're not an easy decision, but we think more likely in these kind of cases, sepsis, and then now IUD, probably we should do it provided all the bloods are normal, probably we should do it immediately. Okay, we have to start doing something, at least it can help, hopefully it can help with her ventilation and also prevention from her becoming more sepsis. So I would say we start, as soon as possible, provided the bloods are okay. And where are we going to do it? Not easy. Not in labor room because she needs ICU care, so can still be done in ICU. Okay, it's just that you can discuss regarding a slight difficulty because there are no midwives available 24 hours in. Okay, I have a few more minutes, is it? Okay, so I've covered, I think,
Another 5 minutes, Prof.
5 minutes. Okay. And then is this patient, let's say, there's contraindication, for example, placenta previa or, abnormalized. So then you have to discuss about cesarean section and then the possible risk in a lady with sepsis to do a cesarean section. And then, of course, in the sepsis, you do a cesarean section, you're worried about, concerned about a future pregnancy, and even more so that this is a small uterus, so you don't know whether the lower segment develop or not develop. All right. So, of course, all this decision is not only, at the medical officer level. So, when you involve multidisciplinary consultant or senior person needs to be involved. Okay, then outline the postnatal. So successful, delivery, for example, vaginal delivery. Okay, what are we gonna do? Okay, you have to look at the fetus, examine, weigh, examine the placenta as well. Okay, you can send a placental swab for culture. All right, and look at the fetus, even though we don't know whether any other things, any abnormalities, something. Even though we know the likelihood of the fetal demise in this case is because of the sepsis, but you need to look at the fetus, just like an investigation for intrauterine demise, in like any other case. All right. So for mom, postnatal, I would say continue with the ICU care. She's not out of it yet. All right. Continue with the antibiotics. All right. Then, of course, you have to continue counseling the husband. Not easy because the wife pregnant and now you lost a baby, but then the wife is also not yet stable. So always update, explain. Okay. And assessment of emotional support for her as well. You never know once you wake up, you have to be prepared regarding that. And you can suppress the milk, the lactation, okay? And you can add in, regarding her subsequent plan for pregnancy, okay? And then because of this severe condition, okay, you never know what's the renal function like. All right, continue follow up with the renal team. Okay, so package 3, even she had a vaginal delivery. All right, and developed renal failure, and then she needs to be hemodialysis, and then subsequently she had a renal transplant. So this is more of a renal transplant question. So the standard treatment for renal transplant, tacrolimus, okay, MMF and prednisolone also. Okay, now she came to you for pre-pregnancy counseling. She's already on transplant. Very good. Look at her renal function, all quite good, except for creatinine, still normal range, but still a bit on the high side. Okay, but normal. So discuss the current prerequisite prior to conception. Okay, meaning that she's trying. She said can she get pregnant or not? Okay, first you can say that she can, even though she's on transplant, she can get pregnant because some people don't know that they can get pregnant. Okay, but with some modification of her medication. All right, and we have to do it to liaise with the nephrologist. Okay, maybe we have to reduce certain medication, adjust the dose of certain medication, but we have to be sure that, okay, to have a successful pregnancy, and we're not sure about this graph, okay, at least a year, okay, no graft rejection. Okay, and she has been in a good condition, meaning blood pressure is okay, no diabetes, or if she has diabetes under well control, and no like urinary tract infection, and then no proteinuria kind of thing, very minimal, for example, and ultrasound to make sure that the kidneys are okay. Regarding the medications, okay, you know this, you know, you have to stop this, okay, mofetil, okay, azathioprine, you can continue, okay, tacrolimus, you can continue a dose adjustment, okay. Steroids, we have to see the amount of steroid, whether she's on high dose or low dose, but usually steroids, I mean, the prednisolone is quite acceptable, okay, because most of it are being, you know, metabolized by the placenta, unless she's really on high dose and long term, then you're worried about effect if she get pregnant, right? Any other associated medical condition, diabetes, hypertension, which is quite common in patients with renal failure before, okay, screen for any other infections, all right? And then, of course, if a counselor regarding the future plan, all right? My time is out, right? Okay, I'm just gonna...
Another 5 minutes, Prof.
All right, okay. So how do you counsel her regarding the future antenatal plan, anticipated pregnancy outcome? Okay, with this blood results that you say and modification of treatment, okay, we can plan for her pregnancy, all right? Stable, of course, it will have to be managed and multidisciplinary. She has to be compliant, come for regular follow-up, okay? And if she's pregnant, we said that, okay, she can come early for test of viability and plan for nuchal scan, for example, anomaly scan. We have to have that, you know, steps, what to do for her from the obstetric point of view. And of course, monitoring of the fetal growth. And remember, even though her renal function now is quite normal, okay, we have to, to see whether her blood pressure needs to be monitored as well. All right. And of course, we have to screen her for all the medical conditions like diabetes and hypertension. Diabetes, hypertension, we mentioned already, risk of preeclampsia in her case. So we have to screen her, of course, for all the urinary tract infection, like here mentioned. Okay. Then in the routine follow-up, okay, there's always a risk, okay. We know her risk of having hypertension is quite high because of the previous, because she's on renal failure before and so on. Okay, even now, okay, even though the renal function is normal, because you don't know the possibility is there, okay, but the likelihood of a good outcome is very high for her case, okay, provided blood pressure is okay, if she has diabetes, is under control, and her medication is optimized, all right? And for the fetus, we are monitoring. We said just now the fetal growth and so on. Okay, so now she vigilantly attended follow-up, multidisciplinary tests, and then on medication, functioning well. And now at 28 weeks, she presented with contraction pain and turned out to be in breech presentation. Okay, so the decision for cesarean section, meaning that we are assessing this. Okay, she has a renal transplant, a graft. Okay, where do you put this renal usually? Usually it's at the anterior wall, isn't it? Or either right or left iliac fossa. Okay, so what are the anticipated difficulties? Okay, this is an emergency cesarean section because it's a 28-week small fetus, uterus probably still small. You don't know whether the lower segment is developed or not developed. Okay, so think about, okay, risk of injury to that transplanted kidney. Okay, make sure that you assess where the position is. You can do an ultrasound scan or get your nephro colleague to come in together during the cesarean section. Okay, but you should know where it's placed. Okay, typically, we said typically, but you should have your renal colleague to, to look at the previous notes, or you can look at the previous note, but at least for them to come in together. All right, so if you have difficulty, you're worried about, causing injury to this transplanted kidney, okay, you can consider a midline incision to avoid that area. All right. And of course, you don't know the inside whether there's any adhesions or not. In case you anticipate that, in case you'll be slow and steady performing the cesarean section. And delivering the fetus, because it's a 28 weeks, just now I mentioned that probably a small fetus, a small uterus, lower segment may not develop. Okay, you can see and assess during that time whether you can do it. If it is there, is it small or big enough to deliver the fetal head? Okay. So you have to think about that. And if the lower segment not developed, the wall is quite thick. All right, so probably up to 1 centimeter, 1.5 centimeters still the uterine wall. So think about difficulties. Okay, now it's a breech. Maybe the buttock can come out easily, but you know the method to deliver the fetal head. And she also has what do you say that contractions. All right, the contractions. So the uterus could be like, you know, hugging the fetus. Not easy to deliver. All right, the good thing is the amniotic fluid is still intact. So you can say, you know, you can deliver it as a whole together with the sac together to protect the fetus. That's another way of delivering a small fetuses in this, you know, premature fetuses. All right, so cesarean section, you know, anesthesia, spinal preferably, okay. And incision, as I mentioned just now, okay, you have to see how big or, you know, what's the width of the lower segment, whether they are developed or not developed. You can do a J incision, okay, or a classical, but you have to think about, you know, what's the subsequent pregnancy like. Okay, preferably, you know, a J, if you can do a J. Tocolitis, depending, okay, if you think that you need to, okay, you can ask the anesthetist just to give you to relax the uterus a little bit, but sometimes it's not necessary, but this is what you can discuss. All right, and the risk of fetal trauma, that's what we mentioned just now. You know, you want to deliver a breech, you know, if preferably you can deliver together. We call it en-call birth. All right, and postnatal management, you list the postnatal management. Okay, combination again, a multidisciplinary. All right, so very early she had a transplant kidney. Okay, maybe in the HDU or ICU, and analgesia. Okay, avoid non-steroidals because you're worried for the kidney. Thromboprophylaxis is the standard lah. Okay, hydration. You know, if she can breastfeed, very good. And discuss on contraception. Okay, any questions? Sorry, I have to go quite fast. Any question?
If any participant have any question, you can directly unmute yourself. Currently no question in the chat box.
All right, clear. People are so tired.
Thank you very much, Prof. Dr. Sophia Sulaiman, for very interesting CPC discussion. So without further ado, I will invite our next speaker for the obstetric CPC discussion 3, Prof. Dr. Rahma Said from UM.
All right. Thank you, everyone.
Thank you, Prof.
Okay.
Okay, guys, can you hear me? Can you hear me, anyone?
Yes, Doctor.
Okay. Okay, Assalamualaikum and good afternoon. So I will continue with the third CPC in obstetrics. So everyone now is ready. You started off with combining rheumatologist, obstetrician. Number 2, you become urologist, nephrologist, urologist, and obstetrician. Okay, so now we are coming to the third CPC. So now you're going to become a neurosurgeon. Okay, everyone, I hope you guys have attempted this CPC package. I don't really need to read, but basically I just want to highlight the important points from Madam S' story. She's advanced maternal age with background subfertility, background medical disorders, preconception, hypertension and diabetes, and they are both medically managed with oral tablets, relatively low dose. At 11 weeks, she has mild symptoms, but basically able to tolerate orally, but clinically has mild dehydration. Blood pressure, not great, not tachycardic, and she's obese. So package 1 question, is basically you can already like kind of make a guess, okay, what do you need to share in terms of how do you manage this patient? So how do you counsel this patient at this 11 weeks? So you know she has all the risk factors for many obstetrics issues. Okay, so this is the marking scheme that's given to me. So basically you are supposed to cover all these aspects of her problems, and at the same time you are going to really elaborate. So what are the risks associated with advanced maternal age? What are the risks associated with maternal obesity? What are the risks associated with 2 common medical disorders in obstetrics? There's also concern with background subfertility. You know, this is high risk on its own, and overall problems affecting this high-risk mom. Okay, so basically I'm sure everyone knows about risk of aneuploidy, and you know how the cutoff of 35 was taken as advanced maternal age. So she's 41, and you know that anything above 45 is considered as extreme advanced maternal age. Some even take anything above 40 as really like higher risk than just 35. So you know that she has all this increased risk of aneuploidy, so that is chromosomal, but it's not just chromosomal. The pregnancy on its own carries higher risk of losses, either very early on. It could also be extrauterine, which is not the problem in this patient because we know this is an intrauterine pregnancy. But you know the risk of this fetus ending up with intrauterine fetal death is higher. So we're talking about obesity. So just now was the maternal age. So she has other risk factors here as well. Hold on. So we're talking about maternal obesity. So her BMI is 33, so it's not so bad. But you have to understand that being obese is already a risk. So at least she doesn't fall under the morbidly obese, but this is enough to put her into additional risk factors. And the problem with obesity is multiple in terms of blood pressure, which she already has. So she may develop superimposed preeclampsia. And the diabetes for her is already pre-existing. So, you know, the complication is even higher. All this preterm delivery, rupture membrane, fetal growth restriction versus macrosomia. So for her, she actually has both problems of hypertension and also diabetes. So this problem may actually, one may dominate the other, or it may just like kind of correct each other. So, but basically you have to closely counsel her about this risk. So the risk of abnormal placentation, which is something that you would need to assess when the pregnancy is more advanced. Risk of abruption, which can also be additional risk on the superimposed preeclampsia, and of course, operative vaginal birth. So how do you go about this? So it's easier to actually systematically approach this antepartum, intrapartum, postpartum, and then also assess the fetal and neonatal risks, and of course, even in the long-term problems. Okay, so basically these are what you guys are supposed to actually cover. So you cover risk of aneuploidy. So what do we need to cover would be offering her either combined first trimester screen, combining with nuchal, versus non-invasive prenatal testing. And she has risk factor to develop preeclampsia. So you may offer her uterine artery Doppler screening, which in her case, with or without a positive screening, she would still benefit from prophylaxis aspirin calcium. And vitamin D is, of course, something that many people advocate for high-risk moms, considering that most of our patients are actually vitamin D deficient. So the obesity also may actually have all this nutrient deficiency. And you know that in obesity on its own, there's higher risk of fetal anomaly. And they can go both ways, IUGR as well as macrosomia. And you know that clinically assessment of fundal height would be very difficult. So in terms of hypertension and diabetes, so this will be, I do not need to actually elaborate on this because everyone at this stage should actually be able to cover all this very well already. Subfertility, we talk about. Okay, so that's 15 marks. How would you counsel this patient, this high-risk patient at 11 weeks? So she actually was rather worried about risk of aneuploidy. So at 11 weeks, we prefer to do all this assessment at 12 weeks because that actually gave the balance of kind of accessibility and the view of the fetus, and things are clearer at 12 weeks compared to 11 weeks, considering that she's also obese. And the other thing, if you really cannot see the fetus well transabdominally, you may counsel her about doing the nuchal scan transvaginally. So that's the scan. And the other screen that was obviously appropriate to be done for this high-risk patient would be the renal function and the glucose control assessment. And true enough, she actually has this some concern with the blood test. And the ultrasound is also not without problems. Basically, the fetal CRL corresponds to date, but there is concern of significant thickened nuchal. The plus point on the scan is presence of nasal bone versus absent nasal bone. This will actually be more worrying versus presence of nasal bone, and presence of normal ductus venosus waveform is also something that is more reassuring. Okay, so combining the first trimester screen with the nuchal and the serum markers. So this patient actually came back as high adjusted risk. So you know that combined first trimester screen, we're talking about adjusted risk. We go by the cutoff of 1 in 250. So for this patient, she actually has high adjusted risk for trisomy 21 and trisomy 18. But she also has additional risk of preeclampsia, which we know from all her risk factors at the start. So how do we interpret these results? And we're talking about the management. So having had this borderline creatinine in the first trimester, this needs close monitoring because this is a patient who is at high risk of developing superimposed preeclampsia. HbA1c, which is high, anything above 6.5 is considered high HbA1c. And this is a predictive of risk of fetal anomaly as well as risk of stillbirth in diabetes complicating pregnancy. Are you talking about nuchal screening just now? Then thickened nuchal is a risk of aneuploidy, but thickened nuchal also is a risk of fetal anomaly. So the uterine artery Doppler, apart from risk of preeclampsia, it also is a marker of IUGR, although the strength for growth restriction is not as good as risk of preeclampsia. So you know that she would require very close monitoring of fetal growth. So how do we go about managing this patient for all these myriad of risk factors? So the keyword is counseling. So what does she want to do with this result, considering that she's actually very concerned about risk of aneuploidy? Okay, when you talk about additional testing after combined first trimester screen, okay, some people may still talk about NIPT because you have to balance with the risk of pregnancy loss, especially for this patient with subfertility, and she's already 41. But what is more important is you need to make her understand, and this is best perform counseling as a couple. Both of them need to understand the risk versus benefit of each option, and also the specificity and sensitivity, because NIPT is still a screening versus diagnostic testing via the chorionic sampling as well as amniocentesis. So this is something that the patient actually has to understand, and they are supposed to be given an informed counseling as well as informed decision, and we would support and respect their decision. And if they do not want to pursue further, then you would offer them a detailed second trimester anatomy survey, particularly fetal echo, considering that she has increased nuchal and she's also diabetic, which has increased risk of fetal heart defect. So that's related to the abnormal first trimester screen. Following that, you know that this patient has other issues that need close monitoring, combined care with the endocrinologist, plus minus nephrologist, depending on the trend of her renal function. She needs to be co-managed with the dietitian to optimize the medical nutrition therapy, considering that her HbA1c is already high. And you know that this is actually a poorly controlled diabetes in first trimester. You know that she would require a minimum of 1 fundoscopy per trimester to actually assess the retinopathy progression. And at the same time, you know that you need to be very careful with the sugar stabilization to avoid risk of worsening of retinopathy if it already is baseline. So prevention for preeclampsia, we mentioned just now, aspirin, calcium at the start. You know, aspirin as early as 12 weeks, calcium some may actually delay until the second trimester, but it is still good if this patient is actually not calcium, you know, not taking much calcium in the diet. And with the blood pressure that is actually not well controlled, the amlodipine, some may actually add methyl dopa on top of the amlodipine, which normally we prefer to change to nifedipine. And we may add on also labetalol, depends on the control, but you are supposed to actually keep a close eye and very, you know, you don't want to bring too low, because the blood pressure may actually be even lower in the second trimester. So it's something that you have to balance the pros and cons of blood pressure control. And you would educate her on the symptoms to watch out for. So regarding her diabetes, the sugar is best monitored with home blood glucose monitoring, and you would need to counsel her about what are the numbers that she needs to target in terms of the fasting and 2 hours postprandial. And if it's actually not well controlled on metformin, you may add on insulin early to make to get a better control. But you just have to be careful if she already has background retinopathy. And this is one aspect that people tend to overlook and underestimate: the optimal gestational weight gain. Okay, considering that she's obese, okay, she still needs to gain weight. She should not lose weight. And usually in this aspect, her to gain less than 10 kilo in until the third trimester. So this is something that was highlighted during Prof. Sophia's screening, CPC package. You're talking about asymptomatic bacteriuria screening, which is very important in patients with very specific anesthesiology early referral to the anesthesiologist colleague for their assessment. And this is important to be planned from the start. Even if everything is fine in the second trimester, you will need to assess the fetal growth, assess the placenta, assess the A5, assess the Doppler studies, because the fetal growth can actually go both ways, too small or too big, and the A5 can go oligo or polyhydramnios, and the Doppler may actually be abnormal. After that, talk to her about timing and mode of delivery, and this woman has to have a VTE scoring at booking, VTE scoring at each visit, and this is a patient who is high risk. Okay, so that's another 15 marks. So 15 plus 15, the third 15 marks comes in third package, where she was brought in the wee hour at 2 a.m. at 28 weeks with seizure, and already managed by our ED team and referred to as with this patient now at 28 weeks with seizure. So remember that all the background risk that she has. So seizure in a pregnant patient or very surprised. Has to be mentioned even if you put examiner may actually fail you. Okay, so apart from eclampsia, you know that a pregnant patient may also have other pathology, but in this patient with diabetes, she may actually have this glucose extreme numbers, either too low or too high, which can also cause seizure. But you also need to worry whether she actually has more than just eclampsia, which usually is self-limiting and not associated with intracranial issue per se, apart from edema or even posterior reversible encephalopathic syndrome. But she may actually have bleeding or even cavernous sinus or any venous sinus thrombosis within the intracranial circulation. Or could this be actually a separate problem altogether? She can actually have a brain tumor. So electrolyte imbalance has to also be suspected because this can also cause seizure. And please also remember about risk of infection. We know that infection can also give rise to seizure, can actually be primary CNS or even other source of infection, but when they become septic shock, they can also cause seizure. So the other not so common TTP can also present with seizure, epilepsy, which we may not have this history in the background, which can actually have these primary medical problems that may just now resurface, or it can actually be exogenous problem. Okay, so drug, metabolic, infectious, structural, and systemic, and other systemic is actually this eclampsia. Okay, so just like Prof. Sohaila and Prof. Sophia's patient just now, okay, you can manage any patient only after you get good history. All right, so considering that this patient is really now not really able to give us history, so you need to actually get history from the next of kin. This is an emergency, inform the senior person. This patient is not likely to maintain airway properly, and this patient needs ICU backup to get the NS referral. So obviously you cannot be certain for many problems without additional investigation. So you can simply do a dipstick and check for glucose, and that can be easily managed. Urine dipstick can be easily tested, and that will give us some idea about her problems with preeclampsia, eclampsia. But she needs other tests that needs to be elaborated, and obviously she will need an urgent imaging. and not forgetting the fetal assessment at 28 weeks for evaluation. So this is something that is very important. You need to protect the airway, maintain the ventilation, and maintain the circulation. So this has to be, we expect that to already be under the ED management, but we need to make sure that this is looked after and monitored well. So we expect her blood pressure to also be high, considering that this is really like post-seizure. So you need to stabilize the blood pressure, and usually in this setting, it will require parenteral antihypertensive. So just go back to Prof. Suhaila's first package just now. The choice of parenteral antihypertensive, either IV labetalol, IV hydralazine, and this patient obviously require magnesium sulfate. And this magnesium sulfate now is working two ways. One is for mom, and also for neuroprotection in the fetus. So after assessing the fetal well-being, so we should alert the neonatologist early. And this mom just need a plan of being stabilized and deliver. And this patient has now to be, you need to update this progress to the close family members, because this is a very high-risk patient. Okay, so that would be management at 2 o'clock. This is all stabilizing and getting to the diagnosis. And when you come to package 4, you already have a diagnosis from the imaging. And this is a very serious condition. She actually had actually been massive intracranial hemorrhage with significant shift. The fetus was viable with 900 grams of weight, and her condition is somewhat stabilized, but this requires definitive plan. Okay, so obviously this patient needs multidisciplinary management. So massive intracranial hemorrhage needs neurosurgical input. So you actually have now to look into, okay, is this intracranial hemorrhage due to the severe hypertension? Is this something else? Okay, because you know that we're talking about intracranial. Is this like subdural, extradural, subarachnoid, or intracerebral? So obviously this is best co-managed with the neurosurgery team, because each location would carry different potential etiology as well as different definitive treatment and plan. Okay, so this patient now needs the family to be involved to be explained regarding all the events that has happened. She's 28 weeks, the mom is very sick, the fetus is very preterm, and you actually also have now to talk about plan of delivery. So obviously this is a high-risk delivery that needs good backup. So backup is everywhere. You need pediatric backup, anesthesiology backup, neurosurgery backup, intensive care backup. So this has to be done after all the team is ready. And in the meantime, you will need to make sure that the mom's condition is stabilized, blood pressure is under control, GCS is being monitored, antibiotics is already, kind of in the plan, and the theater has to be on standby with ICU backup ready. Okay, so post-delivery, this is, the intrapartum. So the cesarean section, we are going to be a straightforward, but you have to understand that this patient, you have to balance the risk of bleeding versus risk of thrombosis. So you have to make sure that the cesarean section is done with good hemostasis, because post-operatively, this patient has intracranial hemorrhage that may also have re-bleeding. So the last thing you want is actually also being callus reflux surgery that may also warrant post-operative risk of re-laparotomy to control intra-abdominal bleeding. So you actually have to be very clear about this hemostasis. So ICU backup is very critical, and this patient you actually have to anticipate postpartum hemorrhage with all the magnesium sulfate on board, and this is a patient who is likely to also have uterine bleeding and sepsis prevention with broad spectrum antibiotic, and of course in the long term this is a multidisciplinary management with neurorehabilitation. Okay. Yes.